Glad to have you here, Dr. Presti. This conversation is very timely, right? We're in October, which is National Substance Abuse Awareness Month. And today we're going to be talking about the opioid crisis and just how intense it was. So I kind of just want to start off, where did this begin? You working in medicine, you were talking a little bit before the podcast about your experiences in medical school with, pharmaceutical companies and people that were, pushing for opioids a lot. And what were your kind of experiences earlier on with these drugs?
Yeah, sure. Great question. Before I answer that, just to clarify, you said that what a problem this was. I mean, it's actually an ongoing, like super entrenched problem in this country. I mean, just to put, I won't inundate your audience with statistics, but just to put a button on it, last year, 2020 was by far the worst year we've ever had. There were almost 90,000 drug overdose deaths, and about 70,000 of those were opioid related, which is higher than it's ever been. So, we're this is very much a present tense type of a conversation, right? Not, something that happened in the past. But yeah, the historical roots of it are, I mean, frankly, kind of nefarious. And, it's a multifactorial issue. So you're never going to be able to identify, one specific thing that provoked it. But I can tell you, when I was in med school, this is, back in 2004, 2005, first couple of years when we were in classes all day, we had a lecture by a quote unquote, pain specialist who was there on a Purdue educational grant.
Right. Purdue is a pharmaceutical company.
Sorry, yeah. So Purdue is the one that has drawn the most ire, sort of from the policymakers and regulatory agencies about the really despicable type of marketing and push to essentially increase at whatever cost the number of opioids that are being prescribed, right? So this was a multi-pronged strategy. I can tell you at least, two touch points where it influenced me and it influenced my classmates and most of the, upcoming docs in America at the time. They used to send these, pain specialists out to medical schools. They would give a lecture over the course, and it always minimized the potential risk of opioids, all right, the potential downsides, the long-term effects, the addiction, the tolerance,
because they're trying to sell it to you,
etc. Yeah, right. There's nothing to worry about here, and in that lecture, I can remember at least twice the guy saying that if a patient has a legitimate indication for an opioid, there's less than a 1% chance that patient would ever be addicted or develop tolerance or have problems with the opioid. I mean, could not be further from the truth. They also then showed us a video that reiterated that same alternative fact, let's call it. But that was just one example of the, underselling the potential hazards, right, of these drugs. Another, nuts example just puts a highlight on how deep this sort of propaganda campaign was and the influence that they had. They were able to influence policy, payer policy, such that if you went into an emergency department and you weren't, number one, asked what's your pain level, right? And then if the patient said a 5 or more on a scale of 10 and you didn't offer them an opioid, your hospital got less reimbursement. Your ratings were affected. So you were providing poor care to your patients. I mean, it really was just so diabolical on so many levels, this pure pursuit of profit. And, honestly, and this is a little bit of a tangent, but that's an issue with C corporations, right? Traditional corporations in this country. If you're an officer of that corporation, your duty is to maximize shareholder profit. Right? Which basically means if you've got a product, your job is to sell as much of it as possible. And it's like, that's the only stakeholder interest you're supposed to care about is your shareholders and maximizing their bottom line. I don't want to go down this rabbit hole too much, but, the whole idea of the social contract and, now that we're treating businesses as, what's the word, corporate personhood, right? So the Supreme Court, as businesses have the right to free speech, they have the same constitutional rights as actual human beings. So, if we're going to extend those rights, then what are we getting in return, right? I mean, you or I, we can be conscripted into the military. We can be told, go die for your country, right? That's part of the social contract that we've signed on for. And, corporations certainly aren't asked to do that. So, I think, and again, this is a definite divergence from the point of our conversation, but, the idea that we should be asking more, and the whole concept of a public benefit corporation and what that means, I think is important, because it allows the people who are running the company to legally consider other stakeholder interests other than just shareholders. So that means, like, well, how is it impacting the community? How is it impacting my employees or the suppliers or what have you? And, honestly, if you're running a business, that sort of long-term perspective is going to ultimately be in the interests of your shareholders,
right?
Because, things aren't just transactional like that. Our country and our culture has become very transactional, but, the real goodness that we have, right, and the strength that we draw from usually comes from long-term relationships. And so those are just as important for businesses as they are for interpersonal relationships. And so, yeah, I think that, that sort of a push is important, because the people who are running the company are kind of required by law to just put that, let me try and sell as much of it at as much of a profit as I can make first. So again, that was a little bit of a tangent, but so part of the problem was the corporate influence on prescribing practices, on payer policy, et cetera. Yeah. And this all began the late 90s, like 99, 2000. This is around the time too that Purdue reformulated oxycodone to be OxyContin, right? And this is another, if you want to talk about nefarious, this was another just mind-blowing example of what they were willing to do. They actually got into the so if you're familiar with prescription medications, they come with a package insert, right?
Right.
A package insert is, we all throw it in the garbage, but
we don't
prescribing docs are supposed to know what all that stuff says, right? So we read it, we know what the indications are, the label claims, et cetera. And it's impossible to get a label claim into that package insert unless you have solid data that supports that claim, right? That's got to be fleshed out with your clinical trials and all that. So it's essentially impossible to put something in there now that isn't true and vetted by science and data. They were actually able to insert into the label claim on OxyContin that, I forget the exact words, but it was something like, extended release formulations have a lower liability for abuse or tolerance, which again was not true, but they got it in there. Then they hired the FDA regulator who was in charge of mediating those label claims. So, again, just so much, back room, behind the curtain, dirty business that went on there. So yeah, that really drove things. And that's why you see, from about 2000 through like 2006, 2007, just this progressive year over year increase in the number of overdose deaths. Many of those, bigger proportion of them back then were related to prescription medications, right? So that number has always floated, somewhere between about 25% and 35 to 40% or so of the prescriptions. So, that's an important thing to point out here, is that, the opioid crisis, the opioid epidemic in the States, it is, most of that damage has been caused by illicit drugs, right? Like heroin, illicit fentanyl. But, it's just a shocking proportion of these overdoses are associated with prescription opioids. And we got to just take a step back and remember, these are medications provided by a physician. Right. So, like you're going to medical school, right? You'll do your white coat ceremony after your second year. You guys will all take an oath, right? I mean, 90+% of med school still do that. And one of the fundamental components of that oath is do no harm, right? Primum non nocere. And that's simplifying things easily, or making it much too simple, because there's always some potential risk anytime you do an intervention. I mean, somebody's got cancer, and you need to do surgery to remove the cancer, or it's going to spread and the person's going to die. Well, there's a risk that the person is harmed during the surgery, right? But it's all a balance of where you're trying to ultimately alleviate suffering, and you're weighing that risk with everything you do, and you're only taking actions where the benefit to risk ratio is strongly in favor of the patient. So, this this is a just like on a professional level, it was unacceptable to me that all of these people are dying from medications provided by doctors, and the idea that we weren't really framing the issue in terms of truthfulness, in terms of the potential hazard, both to the person, to their families, to the people on the street that they're driving next to, especially if they're drinking alcohol with the opioids, which is another major dimension of it. So,
right.
And that's what we're focusing on at SafeRx, and we can get into that in a bit. But so that was the kind of the early my impetus for getting involved in this. Earlier on was the kind of the professional aspect, and then from a more personal standpoint, in the very early days of the crisis, this was 2001, she died, but I lost a dear friend, somebody I loved with all of my heart, to a prescription opioid overdose. She was 20 years old. She went to a New Year's Eve party on December 31st, 2000. She took her prescribed dose of oxycodone. She had an ankle injury, had a few drinks, and fell asleep and never woke up, right? And that's what happens when you combine those substances in the body at the same time. They interact, and you get a much more powerful suppression of the nervous system, right? So alcohol on its own doesn't really affect your ventilatory drive, right? But if it's opioids do, right? And then we call that opioid-induced respiratory depression. But when you put alcohol into the mix with the opioids, that is orders of magnitude greater, right? So that impact is what we refer to as a synergistic reaction, right? So simple terms, instead of like a 10 plus 10 equals 20, it's like 10 times 10 equals 100 type of a suppression of the nervous system, which just dramatically increases the risk of respiratory arrest. So, and it turns out that, based on data from the CDC, almost a quarter, 22.1% was the number they reported of prescription opioid overdose deaths not occurring because the person is, crushing it up and snorting it or injecting it into their veins or doing, some other thing that we know affects the pharmacokinetics, or taking a big handful of the pills. It's because they make this all too commonly fatal mistake of taking their prescribed dose and having a few drinks with it. And, we all, prescribers always have that conversation, right? I mean, the patients generally get that warning on multiple different levels, right? The prescribing doc is telling them, look, you cannot drink with this, it's super dangerous. The pharmacist who's dispensing the medication is telling them, oh, you cannot drink with this, it's very dangerous. There's like a all capitals, bright yellow sticker on the bottle saying, do not drink alcohol with this medication. What the data show is that a huge number of patients, especially long-term opioid patients, disregard those warnings from their physicians. So the data show, there's 5 studies that have looked at this, and it depends to some extent on like what patient population you're looking at. Are they chronic pain patients, or are they opioid use disorder patients? But the number of them, the prevalence of people who admit that they drink with their medication despite the doc telling them not to, it's anywhere from 36 to 81%.
That's a lot of variation.
A quarter of them admit, and about a quarter of them admit to binge drinking. And like some of the numbers are just insane. I mean, it's like 13, 14 drinks per day on average was the number for the people that binge drink or have dependence. So it's just a huge proportion of people that, disregard these warnings from their physicians and from other healthcare providers. And the fact of the matter is the prescribing docs currently have no effective means of preventing their patients from making that all too commonly, deadly mistake.
Right. And like you said, even though there are all these layers already of, attempts to prevent this from happening, and people consuming alcohol with opioids, it's still happening at such a large extent. And this is we can kind of transition into, your solution to this, which I find really fascinating. And so you're kind of creating, we tried putting labels on it. We tried telling patients to do it. But despite these efforts, there is still, there are still a good number of patients that are still having overdoses and having issues because of, like you said, the synergistic effects of these two drugs, of the drug and alcohol. Your idea is to create, and you'll probably explain it in a lot more detail, but to create a medication that is an opioid, but also has a alcohol deterrent inside of it. So when you consume it, if you were to consume alcohol, after you had that pill, your body would, kind of not like it at all, like even from just like a little bit of it, preventing you from drinking anymore and preventing you from getting to a point where that alcohol is, synergistically interacting with those opioids to cause a lot of harm to the body. Is that kind of?
Yeah, you nailed it. You're our new chief information officer. So if you're looking for a position, you could be a brand ambassador for SafeRx. Yeah, so we've developed or are developing a platform of products that we refer to as alcohol-resistant opioids, and we've started with the four over-the-counter, the four prescription opioids, oral opioids that account for the greatest number of overdoses. That's oxycodone, methadone, hydrocodone, and morphine. So we combine those opioids with one of those, each one is a single opioid plus an alcohol deterrent. There's an old medication, the name of it is Disulfiram. It used to be marketed under the name Antabuse. It's actually been out since like the 50s, right?
Wow.
And it's a really cool chemical. I mean, it's what's known as an aldehyde dehydrogenase inhibitor. So alcohol, when it's broken down in the body as it's metabolized, that goes through a series of enzymatic steps, right? And so aldehyde dehydrogenase takes one of the intermediates, acetaldehyde, and turns it into acetate. If you block that enzyme, then if the person drinks alcohol, within 10, 15 minutes, very quickly, you get this rapid, really robust increase in the level of acetaldehyde, right? And acetaldehyde is basically the stuff that hangovers are made of, right? So like you get this really quick onset of this nasty constellation of effects. First, you get dizzy, you start getting flushed, right? The skin gets all red, you're kind of sweaty, then you're like getting a little vertigo. Then you start to get pounding headache and neck pain, and then ultimately like really severe nausea and vomiting, right? And at that point, it's kind of hard to keep drinking.
Yeah.
Party's kind of over, so to speak. But the beautiful thing about it is that enzyme is really not involved in any other physiologic processes. So if you don't drink, if there's no alcohol in your system, it has no effects, right? It's inert in the body.
Right. And you said that this medication has been around since the 50s too. So it's like it's proven over a long period of time to show positive effects.
Tons of safety and efficacy data. When I say efficacy, that though needs to be taken with a grain of salt, right? Because this is a great idea, but it never really took off clinically. And that's, just comes back to the whole reason of like, well, a medication is only effective if a patient takes it, right? So if somebody wants to drink and they know, oh, if I don't take this every morning, I can go back to drinking, then, they're just going to not take the medication. Right. So what we've done, and that's why, if you're prescribing an opioid and you don't want the patient to drink with it, you can't just prescribe provide a second prescription for Antabuse or for Disulfiram, right? Because even if they pick it up, which they probably won't, they're not going to actually take it. So our platform is these are combination products. So fixed dose combinations is the industry term, where there's a certain dose of the opioid, certain dose of the Disulfiram, and it provides patients with like a very straightforward choice, right? Look, if you've got a severe pain condition that requires an opioid analgesic to manage it, then by all means, take the medication that your doctor prescribes for it, but take it as prescribed without alcohol, right? Or you're going to get really sick really quick. As simple as that. And if the patient's like, well, I don't even want it, then they don't need to be on an opioid. Like if somebody's going to choose to drink and not take the opioid, great. Then we have one less person on unnecessary opioid medication. And that's an important point of, what our intention is. We don't want to create one more additional opioid patient, right? We're just trying to convert the patients that we know are high risk for drinking on their medication to an option that's going to be safer for them. And again, that's a huge number. I mean, based on the studies that are out there, it's at least a third, 36 to 81%, depending on the population that you look at, admit to occasional drinking with the opioid. So, like we were talking about earlier, that this is a very present tense type of problem still. We have made a lot of progress reducing the number of opioid prescriptions from the peak back in like 06, 07. But we're still prescribing more than 150 million prescriptions a year in this country alone, right? So there's tens and tens of millions of prescriptions that are going to patients that we know are going to disregard their physician's advice and all the other advice to avoid alcohol. And, that doesn't just pose a threat to those people. It poses a threat to the people around them, right? So their risk of getting into an accident is about 2.5 times higher, right? They also cost way more money to manage. So like just from an insurance payer perspective, that's almost an extra $7,000 a year for the patient who's on opioids and has a problem with alcohol. So, there are a lot of harms and hazards that go along with it. And again, we currently have no effective way of preventing this type of a mistake, even though we know that it's prevalent and we know what the stakes are. So so we think that the new alcohol-resistant opioid platform really have the potential to become a new standard of care, especially in those high-risk patients.
Yeah, I really like the idea because, opioids have become such a standard in society where it seems like we have so many negative consequences because of them, but at the same time, they're so important for, a certain subset of patients that they need these opioids in order to have a good quality of life. And so while we might want to get rid of them because of these other health negatives, these patients need them. And so you recognize that and say, okay, we can still have opioids, but let's add this other thing to it to prevent this negative outcome, right? And so you're understanding that opioids are kind of very important in society and have a big role, and you're just kind of modifying it to be a little safer.
Yeah, that's a great way to put it. It might sound shocking to hear it from the CEO of a quote unquote opioid company, but I can't wait for the day that our technology proves to be obsolete, right? Because that would mean we finally have those non-opioid alternatives that are just as effective, that are safer. I mean, that we're all waiting for that, right? We're all waiting for the thing that can finally turn the page on opioids. But the fact of the matter is, they're not in the foreseeable future. And like you said, there are several conditions and lots of patients who don't achieve adequate analgesia with any other modality or combination of modalities. And so, we're taking a pragmatic approach. It's like, look, let's face the reality on the ground. There are still 150 plus million of these prescriptions getting written every year. Another reality is that a huge proportion of patients we know take them inappropriately by combining them with alcohol. So let's solve this problem. And if at some point in the future it's not a problem anymore, great, we'll move on. But as long as this is such a prevalent issue, we need to be doing something about it. Because, based on the CDC data, we're talking about another person in this country who dies from making this mistake about every 2 to 2.5 hours all year long. Another, 10, 12 people per day are dying because they make this mistake. So again, it's about time we do something about it.
Right. And this particular technology, just kind of checking in and see where is it right now? Like what stages are you in right now? How long do you expect this to kind of, take or become, usable for patients and be prescribed by physicians and
great question.
Doctors?
And it's funny because every pain specialist we talk to about these, who have provided across the board, universally positive responses and enthusiastic, support, they all basically say the same two things. Why the hell didn't I think of this? Is the first one. But then, like, when are these going to be available? Because I have so many patients that I would switch over to this type of a formulation. So we're actually looking at a very expedited regulatory pathway. And the reason we're able to do this so much faster is that legislation that, I mean, I think this was passed back in like the mid 80s. It's called the Hatch Waxman Act. It created something known as a 505(b)(2) regulatory path. So if you're like, take a step back, if you're in the lab, right, and you've discovered some new molecule or compound or whatever, and you think, hey, this might have clinical potential, right? You go patent the thing, and then you do your series of, phase one. Well, first you do your preclinical studies, then you do your phase one, phase two, phase three studies in human patients, right? That process generally takes 9 to 10 years to get FDA approval, and anywhere from $100 million to like $1.2 billion, I think, is the number that's quoted by pharma. So the 505(b)(2), you can leverage to have a much more expedited pathway through it. And the reason why is that legislation allowed drug companies, sponsors, in the FDA's language, to pull forward prior agency findings of safety and efficacy. So if a drug has already gone through all of those clinical trials and it's been found to be safe and effective, and the data is out there, and you can also pull in other clinical trials, even if they weren't used in a new drug application in the past. But you can pull all of that forth. And the rationale behind that is that, look, we need to get meds through this process faster. There's no need to reduplicate studies that have already been done, right? So with this pathway, basically, you have what's called a pre-IND meeting with the FDA, which ours is scheduled for the near future. You present what's known. You present like the gaps in the knowledge and what studies you're proposing to bridge those gaps in the knowledge. And that's where you get the buy-in from the agency that, yes, if the studies that you're proposing come out the way that you expect them to, that would be enough to support a successful new drug application, in conjunction with the prior findings that we've already looked at. So based on that, we anticipate that we'll have our first drug approved and on the market in less than 2.5 years. So, we're talking about like a quarter of the time. And in terms of capital resources, we think we can get our first product approved for less than $10 million. So again, we're talking about a slight fraction in terms of time and capital requirements relative to that traditional 505(b)(1) pathway is what it's called.
Right. And I know you mentioned this earlier about, this being a drug that's hoping to address like the opioid crisis, which is a very big problem in society. The fact that that's what this is kind of aiming for is also helping you kind of expedite the process a little bit.
Yeah, great point. So the FDA has something known as priority review. And if the product addresses something that's been labeled as a national public health emergency, which the opioid crisis has since, I think, 2017, which was way too late to finally label it as that. But if it satisfies that and there are no effective alternatives that solve the same problem on the market, then the FDA agrees to get you that answer, whether it's the approval or it's we need more data, or whatever their final judgment is, within 6 months. So we'll have the NDA, the new drug application, for our first product submitted in under 2 years, actually. And then we expect that within about 22 months, we'll have that drug approved.
Right. That's really exciting, though, like the kind of expedited time frame. I'm sure, going from clinical practice, and this is kind of more of a personal question, but going from a setting where, you're interacting with patients and doing that as a neurologist to now, running this company to hopefully solve this kind of grand issue that's affecting patients you might have seen. How has that been? Like, how has that transition been? What are some things barriers, and like, I don't know, just tell me about your experiences with that.
Yeah, that's a great question, Arvind. So, one of the things so after we got the patents, which was key, right? We got the method and the chemical composition of matter patents on the platform. Right. Which I knew at that point, okay, there's something here that we can start a company around. But the realization just dawned on me that these products have the potential to save more lives in a single year than I ever could if I toiled away in clinic until I was 100 years old, right? So on the one hand, like what's the legacy, right? What's your impact on the world going to be? That was a huge draw for me because it's something that will outlive me, will, hopefully have enormous impact on the world. The logistics of making the change have been stressful, in a few ways. I mean, I was still seeing patients until January of this year. And it was not fair to my wife, my kid, I was basically 120 hours a week of, just, doing clinic, and then immediately and every break in clinic and lunch if a patient didn't show up, and then when I got home, working on the business. And that just was not sustainable. So, we decided to make the move. I also, it was kind of like, in life so often, you just have to listen to the whispers of the universe, right? Like it's often like guiding you the right way. So there were these factors. I was getting burned out with all of the work, not having enough time with my family, knowing that I could be doing something that had a greater impact on society. And I'll come back to it, but seeing patients is one of the greatest privileges ever. I mean, the intimacy, that relationship that you develop, it's such a privilege. And I loved it, and I still do love it. And at some point, I expect to go back to it, at least in some capacity. But those factors were weighing heavily on me. And at the time, our group had just hired a new CEO. I won't say what system he came from or his name, but this was in the middle of COVID. And I had kind of led the shift to, whenever possible, unless we need to lay hands on the patient, certainly for a well patient check-in visit, that definitely should not be done in clinic, right? Like we shouldn't be bringing healthy patients into a clinic where they might be exposed to a deadly virus, right? So if you can provide the care through a virtual visit, then that's the way you should do it. So, I had switched, I think it was like 90+%, or at least 80% of my visits were virtual visits at the time. A lot of my colleagues were like, wow, that's working. We should do that too. And then I got called in one day to the CEO's office. It was just me and him. And he said, I need you to go back to doing in-person visits. I said, well, why? My patients are really happy with the situation, and I'm providing the care that they need, and it's much safer for them. And he said, without skipping a beat, we can't bill as much for virtual visits. And I just I'm not someone who's usually at a loss for words. Usually I say way too much. And I literally just couldn't speak for about 10 seconds. And I turned to him and said, Mark, you realize that what you just said is both like enormously unethical, but also quite illegal, right? And so, at the end of that conversation, he was clear that I had no intention of doing what he told me to do, because I was going to put the interests of my patients first. And we had tension after that, if you go against your CEO. And so, that was kind of the last, I had that conversation with my wife, and I was just beside myself. And I thought, the culture in this place has just gotten toxic since he came in, and it's very much, profit oriented, and that's not the type of medicine I practice. And so, again, it was just this,
it's like a sign,
factors, that like you got to listen, and all of those factors were in place. And so that was kind of, the last straw. That was where I was like, all right, here's my 4-month notice. I'm leaving. So that was backstory on kind of how I came to this. It's hard. The most stressful part about it is, as a doc, you get a lot of like box checking, right? Like most of us are productive people. We like to feel productive. We like to get stuff done, right? And when you're seeing patients all day, it's like, check.
Yeah, yeah,
You're like making a difference. You're helping people, like good pat on the back. Your patients are telling you they love you. At the end of the day, you feel like, yeah, I did a lot of work today and I'm done. And now I'm going to, be present with my family and enjoy a nice dinner and,
right.
whatever.
You feel fulfilled.
Exactly. Yeah. Yeah. Fulfilled, but also accomplished. Right.
Accomplished, yeah.
And I actually did a PhD before I went to med school in neuroscience. And it was this feeling of at the end of the day, so many times, despite working your ass off, just feeling like you didn't get anything done. Right. There was no like major boxes that were checked off at the end of the day. And it just affected. I needed that feeling of, like I have done some measurable good today. Right.
Yeah.
And so that honestly, that has been the hardest shift back, because when you start a business, it's, you check boxes, but they're not like, these are boxes that take weeks or months to check off. Right.
Yeah.
And so it's still a lot of, having to be very intentional about saying the day is done. And like, I've been working on this all day and now it's time to focus on my family and like just compartmentalize that. So I think that's probably been the most difficult adjustment, is that like getting to a point of creating new boxes where you say like, all right, this is a month-long project and this is the part of it I'm going to complete today. Right. And then still having that sense of like, all right, I checked the box, right? I got something accomplished today. But yeah, that's been for me, probably the hardest adjustment.
Yeah, no, I really, that concept of like, what I've come to call it is kind of like depth of impact versus like breadth of impact, right? So like when you're working with a patient, you're kind of like, I guess, deeply impacting one person at a kind of a fundamental level where you're directly interacting with them. Whereas, in the place you're shifting now is like the potential for your, I guess, breadth of impact is so great, like you can affect such a large number of patients, like you said, that you wouldn't have been able to do in a direct setting. And I've always been trying to think like which one is better, but there is no right answer. There's no which one is better or which one's not. And what is really interesting is what you mentioned about that aspect of coming home feeling accomplished at the end of when you're working as a physician, because you directly were able to see that depth of impact versus now, like you said, it's going to take 2.5 years in order about that amount of time in order to get to the point where you're going to start seeing people using all the hard work you've been putting in for so long, which it must be so hard, right? Because right now, I guess you don't feel like you're directly impacting anyone and having an impact on people until I guess you get to that point where people are taking the medication, right? Is that kind of
Yeah. And you hit the nail right on the head. And there's a lot of, I think again, a lot of physicians, most physicians, we like a sense of security, and certainly tend to be planners, right? And like very methodical about how we go through our lives, and like we get comfortable with the whole concept of postponement of joy. Right? No, I'm not going to go to the party because there's a big block exam tomorrow and I got to pass it.
I'm getting ready to go into that.
Right. So yeah, it's risky and there's a lot of uncertainty, and it's very much a gray area, because there's so many things that are out of your control, where you need this to happen in order to keep progressing the program forward, right? Like a lot of what I do now is fundraising, right? So it's doing the pitch and going through like, this is what we're working on, and this is the nuts and bolts of the business side of things, and this is why it's a good investment, and it's an opportunity to both do well and do good, right? Yeah. But at the end of the day, that person may decide to invest or not invest, and that's largely out of my control, right? So it's a lot of, you just got to keep showing up and doing the work, and believing in the process and trusting that it's going to pay off. And one of the greatest pieces of advice I ever got from Craig Kitchens. He was the chief of internal medicine at the VA in Gainesville, Florida. Told me, Mike, 90% of success in life is just showing up. So the point was like, your hard day, your bad day, your good day, it doesn't matter. You just keep the faith, you keep showing up and doing the work and know it's going to pay off in the end. So,
yeah, no, I completely agree. And Dr. Presti, it seems you're very extremely passionate about this issue. The way you talked about it in the beginning, I kind of just let you go on the flow because I could tell you were just so into it and so passionate about the crisis and seeing your role in potentially fighting it. So I'm sure you and SafeRx are going to go far, and I wish you the best of luck with everything. Is there anything you want to say to the audience before we close out?
Well, thank you for that. I appreciate the enthusiasm and the support. Yeah, for the audience, anybody who's listening, we felt that one really good avenue for fundraising that would fit with this is something called an equity crowdfunding campaign. This is the opioid epidemic has proven indiscriminate, right? There's no barriers, socioeconomic status, race, religion, gender, and none of that matters, right? There are no communities in this country that haven't been affected. It's really, truly been a scourge. And so we thought that opening up an opportunity in the form of an equity crowd fund, which really opens it up to pretty much anybody. So the minimum investment is only $500. Doing that, we were looking for this like grassroots type of community-based support, like become part of the solution and join us in this mission, to help fight opioid overdose. So we started an equity crowdfunding campaign, and for anybody who's interested in checking that out or considering an investment, I would encourage you to go to investinsafrx.com for more information. The SEC is very sticky about me providing any details about the terms of the offering or anything like that. So basically all I can say is I encourage everybody to go check it out at, again, www.investinsafrx.com.
Perfect. Thank you so much. And I'll put that link in the podcast description for anyone that's interested. But this was a great conversation, Dr. Presti, really insightful, and really glad I got to talk to you today.
Great. Yeah, you're a great interviewer. Thanks, Arvin. Appreciate it.
I'll see you. Bye. I hope you enjoyed listening to our conversation, and thank you so much for listening. If you love Medspectives, be sure to follow us on Spotify, drop us a review on Apple Podcasts, and share this podcast with your friends. It really helps us grow, and I'd really appreciate it. Thank you so much, and I'll see you next Monday.